Dr. Janice Lee. She's going to talk about APOL1 101, Understanding the Genetics. Dr. Lee is a board certified nephrologist and a member of the APOL1 Action Alliance Board. We're really pleased about that. So she brings clinical expertise as well as personal commitment. In her practice, she works directly with patients living with APOL1 and, of course, on dialysis. So she's witnessed this firsthand, the life-changing impact. And beyond being a practicing clinician or nephrologist, she's a tremendous researcher, and this is one of her areas of interest. So I was real excited when I asked her if she would take a few minutes and explain this to us. And the thing I like about Dr. Lee is that she talks in non-medical language. So she really talks to us. And when I first met her, and she told me at the time I was president of AAKP, she wanted to be on our board, I said, yes, I can put you on our medical advisory board. She said, no, I want to be with the patients. And so that's what I like and respect about her. So we're going to play a video of Dr. Lee and listen up so we can get a first-hand knowledge as to what APOL1, as to what it is.
Hello, everyone. I want to thank the APOL1 Alliance Empowerment Summit Committee for inviting me to speak on APOL1 mediated kidney disease. So, for the next few minutes, I'm going to basically explain what APOL1 kidney disease is. I'm going to also abbreviate that. It's called AMKD. We're going to talk about what it is, who is at risk, how to diagnose it, and what are the treatment options. APOL1 mediated kidney disease is an inherited genetic disorder that affects persons of African ancestry. This abnormal gene, defined as two risk variants of the APOL1 gene, is a gene that originated in West Africa as a protective adaptation against African sleeping sickness. Now that this gene has been passed on, it has been discovered to be toxic to membranes of the kidney and cause kidney damage, which is manifested by excess protein in the urine and abnormal kidney function defined as estimated glomerular filtration rate, or EGFR. When an individual carries two copies, their risk for kidney failure is 3 to 5 times higher than the general population, and that they progress to end-stage kidney disease or needing dialysis 9 to 12 years earlier than patients who do not carry this high-risk gene. We have known for a long time that African Americans have a higher prevalence and severity of chronic kidney disease that has been attributed to high rates of hypertension, diabetes, lower access to healthcare services, poor socioeconomic status, and cultural or lifestyle factors like diet, which is coupled with food insecurities. But now we are learning that perhaps one of the most important factors to consider is genetics, and specifically related to the APOL1 gene. Now, who is at risk for AMKD? We know that around 13% of African Americans have the abnormal APOL1 genotype, defined by two high risk variants. We know that 40% of the African American population carry one lower risk variant. So they're not as high risk as those who have two risk variants. Of those who have the two risk variants, 25%, or 1 in 4 of those individuals, will develop kidney disease. So again, if you have the APOL1 high risk variant, it doesn't guarantee that you will have kidney disease. Again, it's a 1 in 4 chance. But we've learned through clinical observations, research studies, that with the second hit phenomenon, there are certain factors that trigger or accelerate the disease in those with the two risk variants. Things such as inflammation, viral infections such as HIV, and COVID-19 have been known clear triggers for activation of AMKD. Also, uncontrolled hypertension is a risk factor. So, persons of African ancestry, whether they're Black or African American, or if they're Afro Caribbean, Afro Latino, or even individuals with South Asian or Middle Eastern ancestry from regions with historical African migration, can have the abnormal APOL1 genotype. If a patient has progressive chronic kidney disease, persistent protein in the urine, a family history of kidney disease, and or if they have African ancestry, they should be tested for the APOL1 gene. So what kind of test detects this? It's a very simple genetic test using a saliva swab from your cheek. There's no blood test needed to determine if you have this abnormal risk variant. Also, to determine if you have kidney disease, we would do a blood test for GFR. Again, that determines your percent kidney function. And then a simple urine test to detect if you have protein in the urine. The symptoms associated with APOL1 kidney disease vary. The most common symptom, especially early on, is no symptoms. It can be a silent disease, which is consistent with other forms of chronic kidney disease, especially early on. But the blood and urine tests would indicate that one has a kidney problem. Now, those with more advanced disease who may have high amounts of protein in their urine or abnormal kidney function, shown by low GFR, those individuals may have swelling in their legs and feet. They may have foaminess in their urine, and they may have high blood pressure. So diagnosing AMKD also has important consequences related to the ability for African Americans to have successful kidney transplants. It is well known that there is a critical shortage of organs for African Americans in need of kidney transplant. But it is also known that there is a shorter kidney graft survival in kidneys transplanted from African American donors compared to non-African American donors. And this has been shown to be directly related to the presence of the abnormal APOL1 risk variant in the African American donor kidney. Thus, family members of potential kidney recipients may not be ideal candidates for donation if they express the APOL1 risk variant. Thus, it is essential for those family members of persons with the abnormal genotype to be tested to determine if they are indeed a suitable donor, as well as for their own health implications. Fortunately, there is treatment for patients with AMKD. Generally, for many types of kidney disease that cause protein in the urine, there's a plethora of data showing benefit of different medications that affect blood pressure, mostly ACE inhibitors, angiotensin receptor blockers, and the new kid on the block are the SGL2 inhibitors. These have all shown promise in treating patients with kidney disease and protein in the urine. It's also important to have good blood pressure control and have good lifestyle factors such as a low salt diet. However, there's exciting science that has advanced in this area, and that there are in development several chemical compounds in development and in clinical trials that inhibit the activity of the abnormal APOL1 gene. So, persons diagnosed with AMKD can participate in clinical trials that offer therapy to directly target the abnormal gene and possibly show slow progression of chronic kidney disease. In summary, it is so important that persons at risk of this disease and that clinicians taking care of these persons are aware of the need for genetic testing. Persons of African ancestry with a family history of kidney disease or protein in the urine or high blood pressure and known chronic kidney disease that is estimated by abnormal GFR should be tested for the APOL1 risk variants. And then they should be referred to a nephrologist who is a kidney specialist for their treatment options and offered access to ongoing clinical trials. Our goal in this session today is to spread the word about AMKD in as many ways as possible, foster interactions that raise awareness, and encourage more widespread testing. Thank you very much.